My name is Brett Parish. I'm the Vice President of Operations for American Physician Housecalls. We are a mobile practice. Basically, we turn a patient's living room into the doctor's office. So we go all across the Metroplex here in Dallas-Fort Worth area, and typically our average patient would be a 78-year-old white female, well, not white female, but 78-year-old woman who's on probably 11 medications, less than independent with ADLs, probably 2 or more comorbidities, and just doesn't have a good means to get to and from their doctor. So these patients typically overutilize the emergency room, and that becomes their primary care physician, for lack of a better word. So we go into their homes, and so we're ideally using Medicare patients would be our ideal target audience. Treating them, basically offering them, whether the physician or nurse practitioner, managing their comorbidities or diagnoses, whatever it is, their ailment for the day, using more of a preventative model than typically waiting for the patient to have an exacerbation and to be seen and treated. So you are managing their care, their disease, their chronic disease processes, what have you. We offer x-ray, phlebotomy in the home, so the patient really doesn't have to leave unless we need them to go see a specialist. We have 10 physicians, 16 nurse practitioners, 4 podiatrists. Then we also use the phlebotomists who will access the records, and we have the x-ray technicians that we're going to the home, so they'll need it. So we have about 32 licenses in the field at any given day. We are on our 4th EMR system, so there aren't any EMRs out there that really have met our growing need that we place on the EMR packages. So Prima does meet a lot of those needs for us, in so much that everything is built off of one platform. You're not using 2 or 3 peripherals to take care of your billing or the practice management side, and also the EMR capturing the electronic data for the day. We're excited about the replication capabilities to work offline, because our providers will be in some of the most desolate areas, remote areas, and don't have a good connection to the air card that we've typically been using. So to have that ability to document, and then if you lose the connectivity, it's not a loss. You still have the last time you sync, you still have that ability to review the records or whatever you had captured up to date, and it won't just freeze on you. So you're not losing the note, and that's their perception, though it's not really happening. It does freeze up on them when they lose the connectivity. So the offline capability is very important and critical for our success, and obviously reducing the frustration for the providers in the field. So that's something we're really looking forward to in the next version. Beyond offering the meaningful use, I think with the Prima meeting a lot of the already stated requirements on that, that's something that we're very, very eager to also latch on to. With our demographic, our population base being more Medicare seniors, I'm curious how the patient portal access will be utilized for, since we'll have to meet that criteria on the meaningful use definitions they put out there. Because typically, like your grandparents or mine, aren't familiar enough or capable to log into the internet and utilize that access. So I don't know, they're going to have to really refine that if you're looking at a Medicare population right now. I know those that are reaching, the baby boomers that are reaching that Medicare age, maybe not such an issue because they've grown up with the technology, but my grandmother's over 90, that's not going to apply. And so I think there's going to have to massage that definition a little bit better. I'm super excited about, Prima's always been C-CHIP accredited. There are only a handful of EMRs out there that we've looked at, because when we did our due diligence on a Prima, we looked at a few others, ChartLogic, the Next Gen. We looked at a bunch of different packages, what would work best for us. And the one thing that kept resonating with us with the Prima is that they've always been C-CHIP accredited. And though CMS has not come out and said, oh, that's who we're going to use as the accreditation entity to validate all these other EMRs out there, at least you've got a starting point. The prior EMR we used before kind of was a wait and see attitude. Well, we'll wait till they come out and make that ruling, and then we'll meet the criteria. And so being proactive, I think, sets you apart and really helps set a benchmark, and other people are trying to play catch up as a result of that. We've always said the delivery model has been the problem with healthcare, and that's what's bankrupting us, because you could have the cure for cancer across the street, but if you can't get across that street to get the cure, what good does it do you? So these patients either don't have a good, that we see typically do not have a good support structure, they don't have family support or can't get transportation, and so they just wait until they are so dire or so ill that they have to pick up that phone and dial 911 to get that ambulance taxi ride to the ER, and now they're hospitalized for several days at whatever that is. In Dallas, it happens to be roughly 40 grand per hospitalization. So, whether it be an anecdotal story or not, we had a woman who, she passed away in her home at the age of 91 with her family present, had been on her services for a little over 2 years, 2.5 years. But the year prior to joining our practice, she had been to the emergency room probably every month, if not more frequent, according to the family. So if you looked at that and just took that number of 40 grand, multiply that out in that 1 year time frame, on the, push pause for a second, on that 2.5 years she was with us, she did not go to the ER at all. And so the savings we afforded, the system, if you will, are just astronomical, well over $300,000. We asked our physicians to see roughly seven patients a day in their homes. We try to keep their driving distance and drive time down to roughly 50 miles a day. So their round trip travel time is 50 miles. And that's on the obscene days. We obviously try to clump or cluster their visits around a zip code, so they're not all over the Metroplex or all over their territory. And that seems to work out pretty well for us. Now you can't really plan, or you have to have contingencies for those patients that call in and they are ill. And right. Here is now why we were in business to begin with. We want them calling us if it's not a real life-threatening event for that patient. They're just having an acute exacerbation of whatever it may be. We want them to dial us up, and we'll get a provider out there, whether it be the physician or the nurse practitioner or the PA. From day one, we've been on an EMR system, and like I said, this is our 4th one, so we're hoping not to change again. Some of the uniqueness of what we needed for an EMR is just to have real-time data when you have an x-ray that's taken, whether it be an urgent x-ray or one that was just a regular x-ray for a chest x-ray, for instance, just comparing last year's x-ray to this year, looking for any abnormalities or pneumonia, evidence of pneumonia, what have you. That was important to us, to have that real-time access to their charts, their records, either the last note, new notes, consult results. What I really like about Aprima is setting up the health maintenance rules. That's really afforded us to give reminders to the provider saying it's time for Mrs. Jones's lipid panel, or it's time for their A1C. They've got all this information. They need to be using their brain to treat and take care of that patient's healthcare needs, instead of worrying about when was the last time I did this exam, or when was the last time they had their lipid panels done, or their thyroid checked, or what was the digoxin level on. At least if you set the health maintenance rules up in Aprima, based on drug class, based on diagnosis, it will then send them a reminder saying this health maintenance rule is due. They can take action, or they can opt to say, no, I want to wait till the next visit. The patient refused, or take any action on it, placing the order actually. So that was really exciting for me to be able to set that up, to do more of the practice management, so the physician can actually do the treatment instead of worrying about when the last time I did whatever test. We've got 6 super users in our office, and so that really helped delegate out training all these people, all of our providers on how to use it, back office and then the field providers. So if I had advice, you do need to have several super users that are certified on Aprima, that know it in and out, that can help that training or that growing pain time that you'll have, and don't think you can shortchange it. If it takes 30 to 60 days to build whatever it may be, a widget, then don't try to think you can shortchange it by taking 10 days off of building that widget, because the end result, you're going to be frustrated. Providers aren't going to retain that information when they get that 1 day immersion of 12 hours of training, or whatever it happened to be. If you break it up into 2 days, we did that, and we still had people not recalling so much because there's so much information. It takes about 60 days for that muscle memory to be established. So, and then just be patient. These guys are learning this muscle memory. It's just like learning your new phone. If you get a new phone, it takes you a while to get more comfortable with it, and then you start realizing all the new features that are there and what it can do. It's going to take you a good 60 days to get comfortable using it. So the expectation of you're going to see more patients, you're going to be more efficient, you need to be patient. It will take you a good 8 weeks.
Excellent.
Good.
That's what we needed.